Okay, everyone, we're going to go ahead and get started. Thank you so much for joining today. On behalf of the Center for Youth Wellness, it's my absolute pleasure to welcome you all to this webinar on lessons learned through our first cohort of ACEs screening pilot sites. Thank you so much again for joining us today. My name is Lena Singh, and I'm the director of the National Pediatric Practice Community, or the NPPC, which is an initiative at the Center for Youth Wellness. We are excited to partner with ACEs Connection Network to bring you this webinar. And today we look forward to sharing how these pioneering pediatric practices that we had the opportunity to work with have worked to improve care for patients and families affected by ACEs and toxic stress, and to help inform and transform how the field of pediatrics addresses this issue. We really see these practices being at the forefront of this work and truly are proof of the momentum and the energy around this issue. We are grateful to have had the opportunity to partner with these sites and to hold them up as models for the feasibility and the sustainability of this work. So we're very excited today to share their learnings and insights, which have already served to shape this field and our shared understanding of this issue. Before we dive in, I have just a few housekeeping items. Today's meeting is scheduled for an hour, and we have a lot of information to share with you. We hope to have some time after the presentation to answer your questions, so please save them until the end. You can use the Q&A function in Zoom to ask questions at that time. The webinar is being recorded and will be made available afterwards. Please go ahead and mute yourselves throughout the presentation so we don't hear any background noise. And of course, any questions that we can't get to will be addressed in follow-up communications. Here's today's agenda. So we'll begin with introductions to the team that helped lead this project and provide an overview of the NPPC and our pilot site program. We'll then dive into the case studies and how they were developed, looking at lessons learned from individual practices and the cohort as a whole. Throughout the presentation, we'll be highlighting tips and best practices that we've identified through our work with these practices that you can apply to your screening programs. And lastly, a few of our pilot partners have graciously agreed to join us today to discuss their experiences as pilot sites and their journeys to and lessons learned around ACEs and screening implementation. This is who you'll be hearing from today. As I mentioned, I'm Lena Singh. I'm the director of the National Pediatric Practice Community. We have Carissa Luckett, who is our implementation coach for the NPPC. And it's my pleasure to welcome our amazing pilot partners who you'll be hearing from later on. Dr. Mercy DeGangi from Kaiser Southern California Permanente Medical Group, Nancy Tilley from Santa Barbara Neighborhood Clinics, and Dr. Andrea Ruth from Santa Barbara Neighborhood Clinics. So I'd like to share a bit about the National Pediatric Practice Community, or the NPPC, which is a learning community of pediatric medical providers who are leaders in advancing clinical practice around ACEs and toxic stress in primary care. So our goals as an initiative are to engage providers as champions on this issue, to provide tools, resources, and training, coaching needed to make ACEs screening and the integration of a toxic stress framework a reality in practice, and ultimately to become a hub for learning about ACEs and toxic stress as they relate to pediatrics. The project has a few different areas of work. We've convened a virtual community of over 1,000 medical providers around the country and the world interested in this topic, all of whom have access to a very comprehensive online resource center with tools and materials to support screening implementation. Members also receive monthly newsletters, announcements for upcoming events such as this one, and up-to-date information from the field. This online platform helps us promote shared learning, to disseminate best practices, and to also cultivate advocates in the pediatric community for this issue. Our team also provides direct training and technical assistance to a select number of medical practices around the country to implement screening. These are our pilot sites, and we'll be discussing these partnerships in more detail today. This webinar is brought to you today in partnership with ACEs Connection, which is a social network that supports communities to heal trauma and promote resilience. ACEs in Pediatrics is a community within this broader network that facilitates interaction among pediatric healthcare providers and staff. So we encourage you all today to visit acesconnection.com to join this vibrant network, and of course to seek out the ACEs in Pediatrics community in particular. So bringing us to our topic today, NPPC's ACEs screening pilot sites around the country. So starting in 2017, as part of our learning about the integration of ACEs screening in clinical settings, we embarked on deeper learning and engagement partnerships with select medical practices around the country. And we did so for a couple reasons. So the Center for Youth Wellness, as you may know, has an integrated model for ACEs screening and intervention. But we knew that there was a lot to learn about how that model could be translated to other clinical settings and how practices around the country would approach screening. We wanted to build that real-world understanding in varied geographies and delivery settings by closely partnering with practices to understand, to adjust, and to test approaches to integrating screening in pediatrics. This work also cultivated champions that we continue to work with and hold up as pioneers in the field, some of whom you'll be hearing from later today. I also want to stress here that our fundamental approach to this project, we set out to conceptualize ACEs screening in a larger context of clinical quality improvement and practice transformation. So starting to screen for ACEs in pediatrics is a concrete place to begin, but it's part of a larger effort to integrate an ACEs and toxic stress framework and a trauma-informed mindset into practice. So this includes having a widespread understanding of the ACEs science and how that contributes to clinical decision-making, ensuring providers and staff become better able to recognize and address ACEs, using screening to connect families to additional practice level and community level supports as needed, organizing existing intervention supports using an ACEs framework, of course, enhancing and strengthening the relationship between the medical and the behavioral health teams, and ultimately starting to build a larger culture of trauma-informed practice and self-care. So here were the objectives that directed our work with this pilot site cohort. We wanted to identify key drivers and best practices to implementing and sustaining an ACEs screening program by working closely with these practices. So this program was framed as a partnership and a learning opportunity, and these were all practices that had yet to adopt an ACEs screening protocol. To identify and learn how to overcome barriers in screening through tailored content and coaching. So we know from our experience here at the Center for Youth Wellness that implementing screening can be complex. Providers and staff have a lot of questions about implementation, staff training, organizing referral systems, the value add of another screen. So our team provided expert tailored support, training, technical assistance, and coaching around all aspects of developing and implementing this protocol. To facilitate opportunities for a robust understanding of each clinic's unique experience and journey to integrating screening and how these learnings can be translated into strategies for similar clinics. So our goal was to really support these practices to implement screening in an effective and an efficient way, while we also documented their journey and disseminated their learnings to inform the field. We have continually relied upon lessons learned throughout this process to inform ongoing support for other organizations and health systems. And lastly, of course, to increase the number of clinics screening for ACEs nationally. So here are the 6 practices that we partnered with for our pilot site cohort 1. We focused on 5 practices in California and 1 in New York. As you can see, these were mostly federally qualified health centers, and we were tasked with tailoring their ACEs screening efforts to their clinical context and their practices. So for example, we worked together to determine the screening tool that these clinics wanted to use, to define their eligible population for screening, to define what scoring mechanism they would use for a positive screening result, among other things. So La Clínica de la Raza is a federally qualified health center. We're working with their clinic in Oakland, California. Zuckerberg SF General Hospital in San Francisco is screening in one of their multiple pediatric clinics. Kaiser Downey Medical Center is in the Los Angeles area. Marin Community Clinics is a federally qualified health center north of San Francisco. Santa Barbara Neighborhood Clinics is also a federally qualified health center in Santa Barbara, California. And the Institute for Family Health runs the school-based health centers in Harlem Children's Zone charter schools in Harlem, New York. And I will now turn it over to our NPPC coach, Carissa Luckett, to discuss our approach and our documentation of learnings through the case studies.
So, as you can see on the screen, our programs had two phases as we launched. Phase one was where we tested and refined the screening protocol and worked out any barriers along the process and provided training for the staff. We also provided critical patient education that could be utilized throughout the scoring algorithm for patients and their families at various risk categories for toxic stress. Participants also were able to count on a monthly coaching call where we reviewed data and any reporting needs, and they were also recipients of a $15,000 stipend to help cover administrative time and any additional time they needed to provide for practice staff and clinicians. The second phase of the screening included an assessment of spread or scaling of the initiative or looking at how we could sustain or bolster efforts, and provided the practices with a written PDCA and guidance on the next steps toward full-scale implementation or universal screening at all age groups. So as you can see, the methodology we use to set up screening is a performance improvement framework. So in the initial months, we do a lot of work around EHR build and planning for our site visit. In the do section of our PDCA, we actually launch the screening and provide monthly data analysis and the coaching I just mentioned. The study component looks at the analysis and the written summary of the activities implemented in the first 6 months. And the ACT component really looks at sustaining or spreading activities after that thorough assessment. I know this is difficult to read, but you can see from this page, this is what a written PDCA looks like at the end of the 6 months, with a summary at the bottom that talks about the lessons learned, the opportunities for improvement, and the ongoing efforts needed to successfully sustain the initiative. So we feel that it's critical to use a performance improvement methodology because it creates the structure and the standardization for successful implementation. We also know that the actual written PDCA document can be used as a carrot for leadership support, as it can meet requirements for funders or other community stakeholders. It can serve as a basis for a grant or meet HRSA, Patient-Centered Medical Home or PCMH certification, as well as meet Joint Commission standards in the performance improvement standard chapters, the leadership chapters, or the quality improvement. You can also capitalize on the PCMH pre-visit planning and referral tracking and the huddle processes while implementing the screening if you are PCMH designated or are moving towards that. Another critical area that we utilize to help sustain practices efforts are the monthly coaching calls. And these are important because they do give the practices a unique and individualized opportunity to review their own monthly data and for them to work with the coach to identify potential solutions to any barriers they've identified, or even to sometimes uncover potential barriers as we look at the data and reveal, for instance, a high refusal rate of patients filling out the survey has often been linked to the need for additional training of staff members. And so in a given month, if there is a sharp increase in the number of refusals for screening, the coach might ask if there are any new frontline staff that are administering the tool, or if there have been any staff members out on leave, and then work to provide the appropriate training or coaching to staff members who may not be comfortable to minimize the refusal rates and get back on track. It's also a great opportunity for the coach and the clinic leadership to capture and reflect on the positive experiences and the lessons learned, both lessons learned from their staff and colleagues, lessons learned from their patients, and maybe even lessons learned from their referral partners. So it's a good way to capture all of these in small time increments so that you're not trying to remember at the end of a 6-month or 1 year long project all of the positive experiences that need to be documented. So we have also had the great fortune of partnering with the Center for Community Health and Evaluation, CCHE, to provide an ongoing evaluation for the NPPC's initiatives and efforts. And so their goals have been to document the progress and the impact related to the NPPC and to capture the lessons that have also been learned to facilitate real-time learning and improvement. And their evaluation areas focused upon awareness and knowledge related to the ACEs screening, changes in clinical practice and appropriate follow-up. They were also assessing the broader impact of the NPPC on patient care and pediatric practices, as well as gathering additional lessons learned from the implementation of screening and the effectiveness and contribution of the NPPC. In doing this evaluation, they were able to participate on our on-site visits and many of the including calls. They did a deep review of the coaching call notes, looked at the monthly data submission. They participated in their own NPPC enrollment assessment and NPPC participant interviews. In addition to that, they were able to compile a document that included a summary review of our 6 pilot sites and 6 individual case studies that looked at the in-depth findings from the pilot sites. These included not only lists of the screening activities and discussions of challenges, but also went over the results and lessons learned. And these were released in October and are also available online through our NPPC website. Some of the more interesting or high-level results we wanted to share with you today regarding the 6 pilot sites were that they all successfully implemented screening. In the 6 months of the pilot, over 1,900 children under the ages of 18 were screened, and all of the sites screened at least half of their eligible patient populations. The ranges in positive scores were from 7 to 58%. All 6 of the sites made improvements into their data tracking methodology, and at least half of the sites were able to strengthen their referral networks. And we were very happy to report that at the end of the 6-month pilot study, over half of the pilot sites had expanded their screening to either other sites within their organization or other populations or age groups within their organization. So some of the lessons learned that we feel are critical for organizations to have a good understanding of as we encourage you to go forward in screening or to bolster your current efforts are to make sure that your screening implementation aligns with your organizational goals, and really to map out or to look at the potential synergies that can be created so that you can present those to your leadership for enhanced buy-in. And buy-in is going to be critically important. Not only do you need to do it at the leadership level, but you also will need to assure that your stakeholders are included in conversations and from early on. And that includes not only your organizational leaders and your clinical providers, mental health providers, your support staff, your frontline staff, but even any community partners that you may be referring to, so that you can help them to understand the benefits of screening and how that may even create opportunities to streamline the referral process or get their input on how they would like to see any future referrals provide key information so that you can align goals to meet each other's needs as far as prioritization and stratifying patients at greatest risk. In addition, the provider training that needs to occur needs to be not only general and broad about ACEs and ACEs science, but it also needs to include specific information that would be role-based. And the critical piece of this is for it to provide confidence for the effective implementation of screening, meaning frontline staff are comfortable describing how to fill out the tool and the importance of the tool and what it will be used for, while clinical staff are comfortable talking about what a positive score means, the risks of toxic stress, and the benefits of early intervention. A couple of other important lessons learned would be to provide adequate follow-up to make sure that your scoring algorithm not only looks at the strength of your current referral system, but that you work proactively to ensure that you have adequate interventions or referrals as the pilot continues and as you prepare to expand. Now, one critical thing of note is we are not saying that you should wait to implement screening until your referral system is perfect, because we all know it will never be perfect. But make sure that you have some interventions or referral resources available currently, and that there is an adequate level of confidence that patients that are in crises can be seen in a timely manner. There are many number of referrals and resources that you will discover your need for throughout the pilot process, and will give you an opportunity to enhance and build those out for patients and families who may be at an intermediate or low risk for toxic stress that may still have needs, but may not just be immediate needs. And so you can take a little bit more time and thoughtfulness in developing and building out those referrals. I think the most critical lesson learned for us is to integrate your electronic health record systems early on in the screening process, planning and build. It will be near impossible to sustain a screening initiative if you don't have the ability to capture your data related to screening in an electronic record and be able to pull out that data via reporting through your electronic record. And we also learned early on that often the build and the report writing expertise in many organizations were two separate departments within IT, but both needed to be engaged at the earliest onset possible for success. So now I'm going to turn it over to one of my favorite colleagues, Dr. Mercy DeGangi, who is from Kaiser Permanente in Downey, California. It has been a pleasure working with her and all of our colleagues. And so now I'm going to turn it over to Dr. DeGangi.
Hello. Thank you for having me today. This is, can you hear me? Oh,
we can hear you.
Can you hear me now?
We can hear you.
Yay. Thank you for having me today. This is a pleasure. I've had such a wonderful experience working with all of you in the NPPC. I really, truly couldn't have done it without you guys. So yeah, I mean, I just wanted to start off by saying that. Did you guys just want me to go right into the examples I had, or say anything else, or?
Go ahead, Mercy.
All right, so I had a few. I'll just start by saying we've actually screened about 6,000 children in our pilot here in Southern California over the last year and a half now. And so we have a ton of examples, but I had 3 favorites that I had come up with. So I'll try and get those through pretty briefly here. When we first started, I had a 3-year-old come in to see me who was very significantly speech delayed. He basically had like maybe 3 or 4 words. And you know, before we started screening for ACEs, I would have just said, let's go to speech therapy and kind of, you know, maybe screen for autism and go from there. But this child got an ACEs screener at that visit and had an ACE score of 4. And it turned out that the mother and the child had just moved out about a few months ago, where they had been living with a father who had mental illness, significant mental illness. He was schizophrenic and was screaming and hallucinating and punching walls for a lot of the first 2 years of the child's life. There was also a maternal uncle living in the home who used illicit drugs, and there was also domestic violence. And so having that information really changed how I approached. I still sent the child for speech therapy and an autism evaluation, but with the knowledge that there was significant ACEs in the house from birth, and obviously that was affecting this child's development. So we also made a referral to get some trauma-focused therapy as well. And I wouldn't have initially done that without this screener. You know, so that was a really, maybe happened in the first week when we started screening. So it really opened my eyes to how important screening for ACEs is in our clinics. And then I had another one where there were 2 siblings. They were both teenagers coming for a physical. And the girl had some mild depression and obesity, and the boy had recently seen his grades drop at school in the last few months. And I talked to them a little bit, and I talked to them alone. And ordinarily, I would have just referred them to our psychiatry department for counseling. However, their ACEs screen on one of them was 15, so they had gotten an ACEs screener and had a score of 1. And I use this as an example to people of why not to think that a score of 1 just means the parents are separated or divorced, because I asked them privately what they had answered 1 to, and it turns out that their father had just returned home after being in prison for 6 years. So that obviously was a huge deal, and it probably had very significant effects on them feeling depressed and gaining weight and having their grades drop. So it really changed the direction of our visit and helped me understand their symptoms. I was able to talk to the mother alone in my office for about 15 minutes, and she was very tearful and crying and stressed. And so I also sent the mother to counseling as well. So it really just changed the entire trajectory of the visit just by having that ACE score of 1 and actually being screened at the visit. So that was another one I like to use as an example of how it can really open up a visit and really let you in on what's happening in the patient's life. And then my last one, I get asked a lot. We screen at ages 3, 5, 10, and 13. And 13 is, we chose 13 because it's one of the only ages in the teen sector that we don't have any other screeners, and we don't do a standardized depression screening at age 13 like we do at 11 and the older teens. So it's kind of a simpler teen visit. They don't get asked as much generally. And I do get asked, why are we screening at age 13 for ACEs? When we ask teenagers as pediatricians, we do a heads exam. We ask them, you know, talk to them privately about exposure and abuse and things like that. Why is the ACE screening necessary in teenagers if we're asking them all these other questions already? And my answer is because the ACE question still covers a lot of questions that are not addressed by the depression screens and the head screen and everything else. So I had this one 13-year-old girl who had an ACE score of 2. Her other screening questions were negative. I did the whole heads exam, you know, home, education, drug use, abuse, sexual activity, suicide, depression, everything. And she answered no to everything. Everything seemed fine. And since I had her alone, I also said, do you mind telling me why your ACE score was a 2? And she said, okay. And she ended up disclosing that her father and she argued daily. He put her down verbally, and he had pushed her and hit her within the last month. Now, none of that came up with all my other questions, but it did with the ACE screener. So I think that it just gives an opportunity to ask similar questions in a different way, and it's in a confidential way. And I think the patient was just more comfortable answering it in that direction than the more pointed questions, quite frankly. And so I think there's still a lot of value, even with all the other screeners that we do, of adding in ACEs for the teenagers as well. So those are my examples.
Thank you so much for sharing, Mercy. And now we'd like to turn it over to Dr. Andrea Ruth and Ms. Nancy Tilley from Santa Barbara Neighborhood Clinics. Andrea and Nancy.
Thank you. I think I'll go first as the person who's going to talk about the benefits and screening from an organizational perspective. I'd first like to say early on, I have to credit our funder, the James S. Bauer Foundation, and John Clark, the president, and Harvey Bottleson, who was one of their trustees, because they brought community stakeholders together around this issue of adverse childhood experiences. And we spent quite a bit of time in discussion until we could really move forward with the project and leap to what we wanted to do. They were so instrumental in helping us with the planning grant, and then brought other funders to the table that allowed us to do the program the way it needed to be done. And it also helped us to have a really strong evaluation component, that we have 2 very well-known clinical psychologists from the University of California at Santa Barbara, Drs. Miriam Kia Keating and Maya Barnett, assisting us with our evaluation. As an FQHC, we're all about quality care, and this project speaks to informed quality care that will make a difference in the lives for families for generations. And from a leadership perspective, once we were all in, meaning we made time to train all staff members and making sure that they also understood what adverse childhood experiences were, so that they could deal with their own adverse childhood experiences and understand. So as they were being really trained to prepare others, they would be able to understand it from their own perspective, kind of like when you're on an airplane and they tell you to put your own oxygen mask on first so that you can help others. This was the same way that we were trying to train our staff so that they could be helpful. And the process actually normalized you know, the screening process itself, and staff really appreciated the support and the training, and I think it really allowed for buy-in. The screening process has gone smoothly because of the training and the efforts that were put forward, particularly by Dr. Ruth, in making sure that we had scripts and ways of dealing with the screening process and really working it through the full operationalization of the process. And then recognizing that we were not the experts in trauma-informed care. We brought in another wonderful partner, the Child Abuse Listening Mediation, CALM organization. They supported us with training and provided the family therapy component of our program. The CALM staff are actually co-located in the Santa Barbara neighborhood clinics, and that has helped for a smooth and a seamless transition amongst those that are on the care team. So I just want to say that I'm so thankful for the opportunity that the Center for Youth Wellness, and particularly working with the NPPC staff, had such an impact on our program, and we really feel like we so benefited from being a part of this, and it was just wonderful. So from my perspective as a leader in the organization, thank you.
Okay, great, thank you, Nancy. And you can see having our CFO and COO be a partner with me on planning and implementing this project, I think was a key to our success. Our project consisted of screening infants and their parents. And then when we identified a child with a positive screen, which we chose a level of 1 for the child, or a parent who had 2 or more ACEs, then we offered the opportunity to participate in an intervention. And I think for us, having the time to decide in advance what we would do with a positive screen, I think that was very critical to providers and staff feeling comfortable with doing the screening. The process of working with the NPPC and having the monthly calls to look at our processes was incredibly helpful. The intervention that we provided was both a parenting intervention, either in the clinic or in the clinic and at home, as well as what we called wellness navigator services, which is providing concrete supports. And those wellness navigators were able to connect over half of the families to resources that they needed, but I think one of the other important lessons we learned is the most common referrals for us were housing, insurance, and health insurance, and childcare. And that behavioral health referrals, that was only 10% of the people who required a referral. So encouraging people that are implementing screening not to be frightened by the number of behavioral health referrals that you might need. What Lena and Carissa asked me to focus on, though, is about how our ACEs screening efforts have been able to be promoted within our community to a broader effort within our community. So we started screening in 2017 in the fall, and in 2018, another clinic in Santa Barbara, the public health clinic, started screening. At that time, there was a growing interest in the topic of ACEs. We were able to have a community visit by Dr. Nadine Burke-Harris, and she also presented pediatric grand rounds at our local hospital. Our team was able to present at some local community-wide conferences, and then we were able to begin to network with the medical clinics and the different providers that provide services to children who've been exposed to adverse childhood experiences. I think there's also, in thinking about what would be a positive for other organizations, thinking about the integration of physical and mental health within healthcare systems. Now, at the same time, Santa Barbara obviously may seem like an idyllic community, but we've had our own community-wide traumas. We had a mass shooting in Isla Vista. We had a wildfire and mudslide. We had school lockdowns for threats, and we had an increase in youth suicide attempts and suicides. And so this growing, as well as growing concerns about immigration stress and deportation among members of our community. So all of these community-wide stresses added to the, I think, increased interest in addressing adverse childhood experiences. we have had ongoing for years a group called Kids Network, which is consists of all the many organizations that serve youth. So not really medical organizations, but schools and child welfare and family resource centers and juvenile justice and all those other organizations. And they meet monthly. And that organization began to look at the broader issues related to ACEs as a community and trauma-informed care as a community. And so this year, we were fortunate to be able to form what we call our Pediatric Resiliency Collaborative. And this was this vision to bring increased support for all pediatricians in our community to provide screening and receive resources for children exposed to ACEs, and to support family resilience within our county. So this is a collaboration between medical providers and the other agencies that serve children. And what we're doing is sort of in some ways, the process and support that we were able to receive from NPPC, we're modeling some of those same efforts within our community. So this Resiliency Collaborative is providing training and technical support for clinics that want to implement screening and services for children exposed to ACEs. And we have, taken the curriculum that we received and tried to standardize it and think about what are the things that would be most helpful for clinics to learn before they begin screening for ACEs. That's the first pillar, is the training. The second is providing resources. So that's generally the thing that most pediatricians are concerned about. Yes, I'm willing to screen, but what will I do with a positive screen? I'm already so busy. How can I manage one more thing? So what our collaborative is trying to do is provide access to family navigators for these clinics that don't actually have them already in their clinic, and access to child therapists who are able to work with families within the clinic setting. And what we're trying to do is share that resource. So a rotating family navigator that will at least be able to be in each of these clinics at least one day a week, and the child therapist who has a dedicated time. And the difference between what we already have and what we're trying to implement is that what we are implementing is that these two people will be embedded in these clinics instead of having to send a family across town or to another organization. They'll be able to meet with these people within their pediatric practice. And we have a project manager to help us organize those resources. As Nancy mentioned, we've been fortunate to have the support of local philanthropy, private foundations that are interested in children and want to support programs that support children. And I think the reason why it's interesting to them is they see in working on this topic of ACEs the ability to intervene with children at an earlier age, being able to meet with families in infancy rather than waiting till a problem develops at school age, and the ability to promote resilience in children exposed to ACEs. I think it's important as pediatricians that we are willing to share this information with people who may not be familiar with it. Just last month, we were able to present to just under 200 local philanthropists who are interested in funding local projects about the topic of ACEs and resiliency. And we did this in partnership with our other partners, the other organizations that work to support children and families. What this effort that we are working on is doing is that we have 4 additional clinics in our community that have agreed to participate for 2020. And 2 of them have already begun the training process. And then we are hoping to have 4 more clinics in 2021 and 4 more in 2022. I think the response has been very positive. I think most pediatricians believe that it's worthwhile to screen for ACEs, but what they want is a plan and the support to be able to provide services to families who have been exposed to ACEs. So this process for us has been a positive one, and I appreciate the opportunity to take what we've learned and be able to build on the momentum within our community.
Thank you so much. again, a big thank you to our amazing pilot site partners, Dr. Mercy DeGangi, Ms. Nancy Tilley, and Dr. Andrea Ruth, for sharing, for taking time out of your busy schedules to share your expertise and your learnings with all of us today. It's really exciting to see how this work continues to expand and gain momentum at each of your institutions. Before we open it up for questions, I just want to say that on behalf of the Center for Youth Wellness, the National Pediatric Practice Community, and ACES Connection, thank you all so much for taking the time to join us today. Thank you again to our amazing pilot site partners for being part of this discussion. And of course, to everyone we had the opportunity to partner with at each of these 6 practices in our first cohort of pilot sites. And with that, let's open it up for questions. I know that there are some questions already coming in from folks. The first question, and you can go ahead and use your Q&A function in Zoom to ask questions. So the first question we have here, Dr. Mercy DeGangi interviewed a teen who reported abuse by her father, and she used the words confidential way, and I think the question here is about mandated reporting. I think I just want to clarify that I believe Dr. DeGangi was referring to a screen using de-identified items, meaning that the patient family would indicate how many of the adverse experiences the child had had, not which ones in particular. But Dr. DeGangi, do you have anything to add to that? Any additional context?
No, I think you clarified. So yeah, we use the de-identified screener, but then when I spoke to the patient privately, but obviously when we uncover abuse, yes, we report it.
Thank you. And there's a question here. What makes a patient eligible to be screened?
So that's a great question. This is Carissa. When we work with you to set up your scoring protocol, we would ask that you identify patient population that you would like to start screening, and then we write things into the operational definitions for the measure, like say you want to screen 3-year-olds. It would be 3-year-olds at a well child visit, or an annual well child visit. So it has to do with where you're going to capture the data or how you would capture the data to make sure that the participant is eligible. I'll give you another example. When working in the clinic in Harlem, the Institute for Family Health, they had a school-based clinic, so they didn't do a lot of well child visits. They did mostly sick visits. So within the definition of an eligible patient there, it was 13-year-olds who were in for a non-urgent visit. So you can imagine if they were having a pretty significant asthma attack, it wasn't the best time to ask about adverse childhood experiences. But if they had a stomach ache or a headache, they deemed those as non-urgent visits and made sure that they fit into the criteria as eligible. So the term eligible is really very broad and open to how you define it, and then we ask that you define that in writing so that you can follow that very clearly throughout and consistently throughout your screening process.
Great, thank you, Carissa. There's a question here for Dr. Ruth and Nancy Tilley around if you were able to track changes in families who had the intervention with the CALM program, and if so, some of the findings from that.
Thank you. So we are conducting our project as a research project, and the intervention goes on over a year. So at the next 4 well child visits, the parents participate in an intervention with a parenting educator who's actually a therapist. So the actual research project has not been completed. What we have been able to do so far is to just have qualitative interviews with families about the experience and the types of things that they've expressed in those interviews is that they really appreciate being asked, that they appreciate learning the skills as far as parenting and how to what the impact of toxic stress is on their child's development and how to interact with their child, how to play with their child in a responsive way, and that it helps with their level of stress. They've also expressed how much they appreciate being able to connect with resources that they need right at the medical clinic without having to go somewhere else. But the study itself, we're looking at anything you can imagine from the medical record as far as completion of well child visits and development and obesity and asthma control, as well as things like parenting stress and resilience for the infant in terms of how they respond to changes in their routine. So we hope to have answers to those once the research part of the project is completed.
Thank you, Dr. Ruth. There's a question here, or a couple questions here around the screening tools that were being used by the 6 sites. At the point where all of these practices began to screen, we were primarily using the Center for Youth Wellness ACE questionnaire, and many of the practices took that original questionnaire and adapted it in certain ways for their particular practice and their pilot project. So most of the practices were using either the standard version of the Center for Youth Wellness ACE-Q or an adapted version of it. There's another question here around getting honest answers from folks, and I'd like to open this up to either Dr. Ruth or to Dr. DeGangi. Someone's mentioning that they're having difficulty getting honest answers from patient families, and some of the ways that other sites were able to get over this in their initial phases with the pilot. Drs. Ruth or DeGangi, do you have any thoughts around that?
This is Dr. DeGangi. I can add in just what we've observed here. So at Kaiser in Southern California, we're screening at 6 different pediatric clinics in our region. And what we've noticed is that we have a much higher positive diagnosis rate at one of our clinics compared to the other 5. And the only difference, I mean, there are a little bit of demographic differences between each of the 5 or 6 clinics, but the one big difference is how they're administering the screening. So at 5 of our 6 clinics, the receptionist hands out the de-identified questionnaire, and the parents or the teenager fills it out in the waiting room, and then the MA and LVN take the screener and enter the numerical value into our computer system, and then the physician sees the answer and identifies it in the exam room. The one clinic that has a much higher rate of positive answers, which I'm presuming to mean people are more honest and forthcoming on those questionnaires, that clinic, they have a really hectic reception area, and so what they chose to do was to have the MA or LVN administer the de-identified questionnaire directly to the patient in the little cubicle that they check the patient in. And so they explain the questionnaire to the patient face-to-face and go through the questions and then ask the patient, how many of those did you say yes to in your head? And then the patient tells them the number and they enter in the computer. So I don't have an explanation of why that seems to be working so well, but something about the personal touch, they seem to be getting a lot more positive answers on their screener than any of our other clinics.
And this is Dr. Ruth. So we follow the Center for Youth Wellness model. You know, we put this screener in a folder, sometimes with other screeners, have the MA introduce it in the room so that the parent has some private time to fill it out. And I will say I've been impressed by the thoughtfulness that families put into filling these out. They seem to be really thinking through the questions, and because it's de-identified, I think we're getting more honest answers as far as the number. Now, whether, you know, some families want to immediately tell you what it is they've marked as the ACEs, and sometimes they want to talk about that at a future visit. We're connecting them to therapists that are doing parenting education, so sometimes the actual details will come out at a subsequent visit.
Thank you, Dr. Ruth. There's also a couple questions here about the family navigation model. I think folks have questions around the role, scope, and the background of these family navigators, and also, what the structure of this model looks like in terms of funding and being able to bill Medicaid. Can you speak a little bit to that, Dr. Ruth?
Yes, and Nancy, if you want to also chime in. So we have a health promotion department within our federally qualified health center, and these staff members, they are medical assistants essentially. They are bilingual, bicultural, and come from our community, and they are familiar already with, they're certified enrollers for Medi-Cal as well, so they're familiar working with this patient population. It is a very interesting question about whether or not we can bill. We cannot bill separately for these services. But I will say that we have been trying to utilize the data that we have as far as wellness navigators connecting at-risk populations to services. And some of the people involved with our study have actually went just 2 weeks ago to Sacramento to testify on behalf of at the state level as far on behalf of this topic. So I will hope that as we're able to submit data on this information, that we will be able to provide evidence that these can be billed for this service. Carissa did a training with our wellness navigators actually, and connected us to other clinics who were doing similar services. Would you like to say anything about that, Carissa?
Sure. I think that the Santa Barbara neighborhood clinics implemented a really innovative model. They found a medical assistant that really had a special interest in connecting with patients on a deeper level, and so it really worked more like a community health educator model, because the medical assistant is a member of the community, and has a very open and caring personality. And so we just did a lot of training around assessment on Maslow's hierarchy of needs and using motivational interviewing techniques. And so the cost burden to reallocate one of their medical assistants in this way was not a burden for the clinic, as you can imagine, and they had great outcomes utilizing this model. The other clinic that we had participate in the Navigator webinar used a very similar method as well.
So some of the clinics that we're working with are going to be using Family Resource Center advocates, and they have already a way in which they work with families to assess protective factors and support the strengths of the family. So I think that's another option if you have either First Five in your community. They have already a plan where they work with families in that regard. So you could bring that organization in perhaps to work with you.
Okay, I think we have time for one more question. As I mentioned, thank you, Dr. Ruth, for sharing, and Carissa. Of course, any questions that we have not gotten to, we will be addressing in follow-up communications. But we have someone here, one of our participants today, who is presenting to a group of leaders and understands that buy-in from senior leadership is important for this kind of process. But is there one thing that this person could stress in the presentation that they'll be giving that can help support the need to screen? I'm hoping that some our pilot partners can help answer this question. What is the one thing that this person could stress that would support the need to do this work?
Well, this is Nancy Tilley. I would like to say that as of the 1st of January, all Medi-Cal patients are going to have to be screened. So the work is going to have to be done anyway if you're seeing Medi-Cal patients. I mean, it's really good medical practice. They think that if you're going to screen a certain segment of the population, it makes sense to, again, normalize and screen everyone instead of having people being treated differently. So that would be, for me, that would be a real compelling argument.
This is Dr. Gadanji. I would just say that it just opens up so much more information about your patient and what they're experiencing. I mean, it's completely changed the trajectory of my treatment plan many times. Once I find out what's going on within the family and within the patient's mind, that has really, it's really made a difference in how I refer the patient, how I treat them, the type of follow-up that I do. So I think it's pretty significant to do these screenings because it really affects patient care.
Okay, thank you all so much. Again, want to extend our thank you from the Center for Youth Wellness, the NPPC, and ACES Connection for joining us today. We really appreciate you taking time, and of course want to thank our pilot partners for taking the time out of their busy schedules to share their learnings with us. Thank you all again, and with that, we'll be ending the presentation.
Thank you.